As a speech-language pathologist or speech therapist, as we are otherwise known, we play an integral role in the assessment and management of children with cerebral palsy, or CP. This video will briefly discuss the role of the SLT in the lives of children with CP. So we would typically start with an assessment, and here we would start with a case history, and within this case history component we also look at the medical file and review the intervention and various diagnoses made by other professionals. As part of the case history, we also complete an informal interview, and this is usually based on the parental or caregiver concerns, and this is due to the fact that this is where we would typically start. So we would typically start with the greatest concerns or difficulties mentioned by the parents. Overall, we observe throughout the session, but then based on the information gathered from the parents or caregivers, we would typically observe the concerns and prioritize these. So for example, if there are concerns related to feeding, we would try and observe the caregiver feeding the child if that was the biggest concern. And there are various areas we would typically assess, and with children diagnosed with CP, we cover all the areas related to our profession, such as communication, which would include your speech and language components, as well as feeding and swallowing, and then also literacy. So because of the range of abilities of the children with CP, we use the GMFCS, the MAX, and the CFCS to provide us with a functional classification of the patient. So let's go a little bit into assessment. When we assess feeding, we typically observe the caregiver feeding the child, as this hopefully gives us a clear image or understanding of the feeding method at home. So the observation component is really essential, as caregivers may describe feeding to you as normal, but the normal may not be safe or practical, and they're just so used to feeding the child in a certain way that has become normal to them, no matter how stressful it may actually be for them. So I typically try and observe feeding, even if it's via a feeding tube, such as a gastrostomy, just to ensure that there's adequate positioning for these feeds as well. And then we would then observe the posture as well as the positioning of this child during feeding, whichever method of feeding is used. So feeding is of paramount importance in this population, as children with CP are at an increased risk for poor weight gain, constipation, and of course aspiration. During this component of the assessment, feeding is assessed by looking at the method of feeding, the time taken to complete the meal, the child's state before, during, as well as after the feed, and then ultimately the safety of the feed. We always aim for the safest, most effective and efficient feeding method that is beneficial for both the caregiver as well as the child. So in this population, we may find any of the following that may contribute to poor feeding. So some of these would include an open mouth posture, tongue thrusting, as well as poor bilabial seal during feeding or even a tonic bite. Some kids also have some tonal difficulties which may affect these areas. When assessing communication, we assess how the child communicates their needs and wants and how they protest in response to an undesirable action or item. These are essential for us, as we can then observe and assess whether the child has communicative intent. We also observe the emergent literacy skills and their joint attention, turn taking, and then their overall attentiveness, which all affect communication, whether it be verbal or non-verbal. So you will note that I have not focused on speech immediately, as we prioritize communication over speech for most children, and especially in this population, we often find that these kids may be significantly delayed in communication, and we try our best to establish a mode of communication earlier on that is effective in getting the child's message across to state their needs and wants. So going on to the speech component of the assessment, children with cerebral palsy often have difficulties with speech production, as the oral muscle tone may be affected, so they may be hypertonic, and this may result in a motor speech disorder which we call dysarthria. In this disorder, speech sounds, or articulation, respiration, phonation, resonance, prosody, as well as intelligibility may be affected, and therefore this is an area that we often try and assess to establish whether or not we have any difficulties. So then we would also assess language, which is often influenced by the cognitive level of the child. Children with CP may have both receptive and expressive language difficulties. Therefore, this is an area of utmost importance for us to assess. And for those identified as potential ASC users, language plays a role, as we would gradually add vocabulary and various language concepts into the AAC system chosen for the child. To assess language, we could use both formal or informal assessments based on the functional level of the child. So moving on to intervention, the first item on the list for these kids is positioning, and we depend so much on our OTs and physios to assist us with adequate positioning. as it is important for both feeding as well as communication. So once this has been established, we would then move on to the feeding or and swallowing intervention component. So when we do feeding and swallowing intervention, we focus on the manner of intake as well as the recommended diet. So this would be in terms of the consistency based on the speech therapy. The speech therapist would look at the consistencies that are safe, and then the diet in terms of quantity is what the dietitian would decide and would look at. We would then liaise with our MDT to determine the best method of feeding to ensure that the child receives the necessary nutrients in the safest manner. And there are times, so as a team, we would discuss and a decision would be made for 2 feeds. And an example or one of the reasons for this might be if we've tried to establish oral feed safely and still have difficulties with nutritional intake, or there's a great risk for aspiration and recurrent chest infections due to chronic aspiration. So we have various techniques we use to assist in improving the oral phase of the swallow of a child with CP. Some techniques to help assist in creating or encouraging bilabial lip closure during feeding would hopefully also reduce the amount of spillage or food that the child misses during the feed. So those are just some techniques that we might use. So for the intervention for speech and language, for those children that have speech and language difficulties, there are some techniques that we would use in therapy, and we would also train the caregivers to use these at home to encourage and improve their speech and language development in the home environment. These include but are not limited to modeling, imitation, expansion, and shaping within play. In terms of the management of ASC, once we have assessed whether the child would be a good candidate for ASC, we would then begin training the child as well as the caregiver or parent in the use of the device or system. And there are various systems to choose from and are often chosen based on a variety of factors. Some systems that are what we may call low-tech, and then others would be called high-tech systems, which are all beneficial and are vary based on the child and their circumstances as well. Typically or ideally, the child will be able to use the ASC device or system in everyday life as you and I might use speech. So essentially, the device is their voice.